Okay, we'll go ahead and get started. But before we get started, I want to make everyone aware that we are recording today's session. So you've all been warned. Okay, welcome, and thank you for attending the HTA, Innovaccer, and Meharry Medical College webinar on predicting adverse maternity outcomes and discussing treatment approaches. My name is Chris Coy. I'm the VP of Data Analytics for the HTA. Also joining me are Rob Andrews, our HTA CEO, Carla Zolby, our Chief Engagement Officer, Marianne Seminitz, our VP of Customer Engagement. So we'd like to take a moment and introduce our speakers for today from Innovaccer Meharry. And you'll see that coming up here in a second. Here we go. So for Meharry, excuse me, from left to right, we have Dr. Britt, Dr. Southpaw, Dr. Graves, and Dr. Hills. Dr. Hills is at the bottom right. And then we have Dr. Nace from Innovaccer. So I won't read their titles and all of their qualifications, but this is a very accomplished group. We're really thrilled to have them here today. So thank you for joining us. Marianne, if you will go to the next slide. All right, to get things started, I'll be providing you a brief overview of the HTA and the ideas behind the maternal health outcomes analytics exercise for which we engaged Innovaccer, and we're basing this session on today. So you'll hear from the Innovaccer team regarding details of the analytics exercise that they conducted with us, focusing on identifying high-risk patients and predicting high-risk complications. Then the team from Meharry Medical College will discuss treatment approaches to positively impact the health outcomes of at-risk women in maternity. We encourage you today to ask questions throughout the webinar, and we have also left plenty of time for the Q&A at the end. In order to do that, please submit questions. The easiest way to do that is through the chat feature in Teams, which is on the upper right-hand side of your Teams bar, if you can see it up there. Or you can also email me directly if you prefer to do that, your question at ccoy@htahealth.com. It's up there on the screen. Again, ccoy@htahealth.com. Myself and Carla and Marianne will be monitoring chat and my email, and we'll make sure to get your questions asked and answered by our expert crew here today. All right, a little bit about the HTA. So founded in 2016, the Health Transformation Alliance, or HTA, as we refer to ourselves, we are a member-owned cooperative of over 60 self-insured employers across the US. Ultimately, we are focused on improving health outcomes for our member companies, employees, and their families, and reducing healthcare spend. One of our goals that we've always had is to use data and our aggregated data that we have from our members to improve healthcare outcomes for the members, employees, and their families. To set the stage for the conversation today, we're going to go ahead and talk about maternal outcomes, and let's go ahead and go to the next slide. Thank you. So it's critical that we're all grounded in the facts around maternal mortality crisis in the US. Unfortunately, and this has been well documented, we have the highest maternal mortality rates among all developed nations. This obviously has both a direct and indirect impact, including at the most catastrophic, the loss of human life, the emotional toll on those experiencing the loss. Obviously, for the community, it results in poor outcomes in healthcare and quality of care that's not meeting our patients' needs, especially during the maternity episodes. From a business perspective, the impact it has on the community is reduced workforce performance and ultimately lost revenue that we have in business. So really critical, important outcomes that are being affected by this. So knowing the impact of this crisis that we're under, we, the HTA, partnered with Innovaccer to have them use our unique de-identified data aggregation. This is claims data of over 139 million medical records, along with social determinants of health data. And we did that to help identify the top 10% of high-risk covered lives and predict high-risk complications, not just during pregnancy, but prior to pregnancy, during pregnancy, and postpartum. Because we wanted to understand more about how we could take this study and what we learned from the analysis and the exercise to have a better outcome, we decided to partner, and we had the privilege to connect with the Meharry Medical College. And we approached them with how to mitigate these issues and how to ultimately have better outcomes for moms and babies. Meharry Medical College is a top HBCU. They are located in Nashville, Tennessee. And we're very excited to have them here today because they're going to share with you real life solutions to the problems that we're seeing in this analytics exercise and in reality across the nation with the disparities in maternal outcomes among women of color. Okay, so I'm going to turn it over next to Dr. Nace from Innovaccer. He's their their Chief Medical Officer for Innovaccer. He's going to speak to you more about this analytics exercise. They partnered with us. Once again, we're going to be, if you have questions as we go through this, please put them in chat and we'll make sure to get your questions answered. All right, Dr. Nace.
Yeah, thanks, Chris. Really thrilled to be here today. It's such an important topic. I've worked for the majority of my career with employer side as well. I've helped the benefit side for large employers I've worked with, and I've worked with employers trying to improve their health. So I understand the goal for employers is to really keep their workforce and their workforce families healthy and well, and to do that at low costs. And the challenge they have is they often have small benefit teams. They aren't experienced in healthcare. They don't do healthcare services or interventions. And all they really have is claims data. Claims data is lagged. It has a lot of restrictions to it. Nonetheless, there's power in data. And so the wonderful thing about HTA is they can bring such a large cohort of employer data together. Even though de-identified, there's enough information to really learn some things about. And the initial engagement was particularly around this crisis that we have for maternity care in this country, trying to identify and develop a predictive model that could do two things. One is use both clinical and social determinant of health data. There is some in the database itself, the demographic data, age, marital status, etc. That all comes with insurance data. And then others in which we use proxies for, such as a zip code as a proxy for what we know from public information about population of race or speaking or distance, travel, food deserts, etc., etc. And to be able to look at doing two things. Using advanced analytics, particularly an unsupervised learning model, for those of you who are data geeks, to really identify those things early before pregnancy and in the immediate onset of pregnancy that would identify adverse outcomes. Adverse outcomes during pregnancy, in the perinatal period, and postpartum. And then we use the machine learned model to take a look at events that occurred during the pregnancy that would move someone from a low or medium risk into high risk. And this is very, very important because D. Eddington in the University of Michigan, I think for those of my colleagues who remember, he's done this for 30 years. When you look at identifying those people that you want to deliver services to, high risk individuals, they don't start out high risk. They start out as low or medium risk, and then something happens that moves them into high risk. And so there are events that occur along the way of pregnancy that if one could develop a predictive model to identify them, you could immediately address by offering clinical and social services to them to help to reduce that risk immediately. That was the opportunity that we wanted to see if we could validate a predictive model to do. So we go to the next slide. Great. We did learn some very important things that are the basis for the discussion that we're going to have with our friends from Meharry. So number one is we looked at this employed population, and again, in the literature, we have lots of this information about health inequities around maternal care from the Medicaid information, from government literature, but in an employed population, what we saw was very similar to what we know already in the literature. One is that 10%, this far 10%, breaking out the cases into cost cohorts, they drive the vast majority of the care. 48% of the costs are being driven by just 10% of the individuals. We kind of expected that, we know it, but now we know it in an employed population, particularly this particular cohort of information. So if we go to the next slide. Knowing that these adverse outcomes, NICU care, C-section, etc., or drive these high-risk costs, we then were able to show that pre-existing conditions. Remember, we were taking a look at before pregnancy and the onset of pregnancy. That pre-existing conditions actually did predict in the claims data a higher percentage of adverse outcomes both during pregnancy, during delivery, and in the postpartum period. So you can see here, looking at a hierarchical category condition list of disorders. If we take those who have 4 or more, it could be skin condition, it could be a GI condition, etc. But 4 conditions, remember this is machine learning, so we're not taking any biases, we're just using the data to find out what the data can show, we see that having 4 or more conditions actually show a higher incidence of both adverse outcomes in pre, during, and postpartum periods. Same with those who have circulatory disorders, except we knew already, and this is confirmatory, those, for instance, that have hypertension have a higher risk of having adverse hypertensive episodes. But we know that mental health also drives a huge prediction of these adverse outcomes as well. And obviously, a case of infertility can drive that as well. It does speak to a predisposition. So that goes to this, how do we find in the data those conditions that drove a higher percentage of outcome of these adverse outcomes, a higher percentage of the adverse outcomes in each of these periods of time. So if we go to the next slide. We also found, well, using the social determinants data that we had, and I mentioned we have demographic data in the claims data, so whether or not they're married, single parent households, mothers over 35 years, these were higher predictors of complications during pregnancy and during delivery. And then also, using zip code data and national information about those zip codes, we were able to find that births in regions that had an African-American population greater than the national average, or those in which Spanish-speaking populations were greater than the national average, also had a higher risk of adverse outcomes during pregnancy and during delivery. So that's the foundational data that we began to build, do our analytics on and build this predictive model. So if we go to the next slide, because
Dr. Nace, can I ask you, a question's come through, and I think it might be good to ask on this slide. You were talking about the social determinants data. The question that we received was, did you actually have race and ethnicity data in your data set? And I know the answer to this, but do you want to?
Yes, of course. So, I mean, this is one of the challenges that I'm sure we're going to get into the discussion with our friend Harry, is that in general, when we take a look at, now there's 2 cohorts of data that we generally talk about in healthcare: clinical data that we collect at the healthcare system or the outpatient or clinic, and then we have claims data, stuff that gets submitted to the insurer, and that's the information that we're leveraging here. In both sets of data, we are often missing information about ethnicity and race, and that is a national topic of itself that I'm sure we're going to get into that needs to be addressed. I'll also point out one of the other big pieces of information that we need to do is to take a look at the duration of care that's given postpartum. That's another big foundational driver of this crisis that we have, but we'll get into that in a little bit. But you'll notice here we use zip code because that is the proxy that we can use to find demographic data and ethnicity data.
Yeah, and I'll just add to that, we did provide de-identified data extract. So for those of you who may not be familiar, when we de-identify data, the only piece under HIPAA that we provide is the first 3 digits of the zip. So ideally, it would be great to get down to street address and that type of thing. But in a lack of that, we did proxy for that race ethnicity data. So the question on there is, we did not have that, but we did have some of these features that were coming out of our social determinants files based off of geography.
And from a clinical standpoint, because claims data lags, generally we think 6 to 12 months after the fact, this goal of developing the predictive model that we're going to talk about in a second was the ability to identify during the course of time, during the course of pregnancy, when someone goes from low or medium to high risk. And that's a crucial element, right? Because that's when you can intervene. Claims data often lags and has those limitations. So from a care delivery perspective, developing a clinical predictive model for those who are actually in the care delivery process is critical. You need to use claims data really as a foundation to start to drive these sort of models, particularly such a large cohort of data. But you're absolutely right, Chris. We used the proxy that we could. You would get more with a zip code. You would get even more if we routinely collected race and ethnicity data in the clinical data itself and the claim submissions.
And one other thing I'll just mention here, the outcomes that we saw here, part of the reason that we, the HTA, were interested in working with Innovaccer on this study was to see these are some of the outcome disparities that we were hearing about in the general publications that were out there. A lot of data sets that are actively used typically are Medicare data sets. Now, you don't get a lot of maternity claims in that. So this is one of the things where we as the HTA, since we're payers, we're employers, we have a lot of active claims. We want to see if the same patterns existed in our data. So we were trying to answer the question, are we seeing these disparities? Do these actually exist? And the answer, unfortunately, is yes, they do. And they're consistent with what's out there. So this was a big piece of information for a lot of our member companies.
Yeah, absolutely. It's a big, I think, piece of information for the industry at large to know that many people think, well, Medicaid populations are so different than an employed population. What we're finding out here is, well, maybe not.
Exactly.
So if we go to the next slide, and this was the fun part, because this is where we use the actual advanced analytics and machine learning. We actually, as I mentioned before, we wanted to identify at the beginning of pregnancy, what are those individuals that are at high risk for these adverse outcomes? So we did that using both claims, medication, and this 3-level zip code along with demographics, as I mentioned, age, marital status, etc. And then also began to put that into an engine to say, what were the elements that predicted high risk of having adverse outcomes, medium risk, and low risk? And then we wanted to take a look at, okay, if someone then becomes pregnant and you were able to take this information, which you'd be able to do, the social determinant, the medication claims history, and say, here's the risk bucket they're in. When do low and medium risk suddenly become high risk? What are the events that happen during the course of time? And would one be able to predict what those events are? That when they occur, one would require immediate intervention to reduce the adverse outcomes. That was the goal in doing this. And this took a machine learning model to really get at it. But we were able to then be able to show right here and then test that model to be able to show what are the things that occur during the course of pregnancy that would predict specific outcomes such as C-section, gestational edema, non-routine NICU care, et cetera, et cetera. So if we go to this next slide.
And before you get into that, we do have another question that just came through chat if you want to tackle this one. So
Sure.
Thank you, Karen, for Dr. Scott for submitting this. So regarding social health determinant, I'm curious about the use single parent households. How are you interpreting single parent households risk or protective? And did your analysis consider defining and measuring the number of adults within a household who contribute to childcare, household expenses, or both as social determinants of health?
And this is the interesting thing in doing analytics, is all about the data and what does the data tell. Not that we predict the data to show us and therefore biasing or skewing. We simply look at the data elements that drive a higher percentage of risk. And so this was a data element in the claims data that was able to show a high percentage of risk, that is a single parent home. There may be other ways to cut and slice that data and show a lower percentage of risk, but this one stood out.
And I will also say, I think Dr. Nace, correct me if I'm wrong, but we used the one of the proxies or one of the social determinants files that we used was the CDC Social Vulnerability Index. And that in and of itself has a lot of those measures. Again, it's geography based, so it's a proxy for a lot of the details on whether we actually know the level of income. We don't have level of income necessarily in our claims data. That's not something that comes through on a traditional eligibility file from a claims administrator. So some of those things come through, and we use the social vulnerability index to look at things that are associated with that geography. Is this an area where a high preponderance, greater than average, have a high number of single parent households, or they have households with dual income, or those types of things? So that's how we end up using it from a proxy standpoint. Good question. Hopefully that answers your question.
Yeah, okay. Thanks. And so this is just the results of really testing the model. So once again, we took unsupervised learning before pregnancy. Look at all the events before pregnancy. Person, is now pregnant. Do they have medical conditions? What are their social determinant of health data that we have? And then be able to show that prediction of risk. And then we use this machine learn model to say, what are the events that occur during the pregnancy that might predict specific adverse outcomes? And what we then did is circle back to the data, now unblinding the data source to what happened after pregnancy to say, were we able to predict accurately the event that we expected to predict using this machine learned model? And what we found is in the prediction of these 4 conditions, gestational diabetes, C-section rates, C-section, preterm birth, and postpartum depression, the model had very good predictive validity in being able to predict those folks that move from high or medium risk to low or medium risk to high risk, and therefore had an adverse outcome, and actually able to, with a fairly good precision, predict the actual outcome itself. So this was our first time doing this. We were so thrilled to have HTA give us this data set and allow us to do this sort of work. I think it lends itself to saying this might be an opportunity to use this sort of predictive model using machine learned prediction models to be able to then apply them in the clinical setting to leverage all of the wonderful learnings we know about where we can reduce health inequities, where we can improve outcomes for maternity care, and how we can improve the health and wellness of not just employed individuals and their families, but also our population in the U.S. as well. So,
Dr. Nace, we have one more question that came in. How far out did you measure postpartum depression? 6 weeks, 1 year?
Yeah, I would have to circle back in the data set to see, because we did have some limitations on the full report out, but we went out as far as we can for a year.
Great, thank you.
Okay, I think we are now at a point where we're going to switch gears in the presentation and bring in our friends from Meharry. If we go to the next slide.
Yeah, and I will point out that last question is critical, because the collection of data postpartum is often limited. You know, historically, people only looked out 42, 45 days. Other times, people are now starting to look out longer and longer for a period of year in terms of both reimbursing for and developing care. And a lot of these studies have begun to convince public sector and private sector to extend their care coverage out to a year, not just for the immediate term post-birth. In some cases, insurance coverage ceases immediately after birth or shortly after.
Well, those of us at Meharry are happy to be able to participate in this discussion about how we can reduce our maternal mortality in our local community in Tennessee and Davidson County, as well as nationally. We are a historically Black medical school that is more than 146 years old, with a motto of worship of God through service to mankind. So the goal of all of the activities of our 4 schools within the college relate to identifying those vulnerable populations that for years have not received equitable care, and then to determine how to provide them the best care. So in order to do that, one of the major aspects has been women's health and taking care of those during their childbearing years. And I'd like to introduce Dr. Allie Britt, who is our Vice President for Faculty Affairs, but has spent a lot of time working with the Tennessee State Department of Health to really look at maternal mortality, to introduce what's happening in Tennessee.
Well, thank you for allowing me to share. In my 12 years being with the Tennessee Department of Health and the last 2 working around maternal mortality, I had the opportunity to see our evolution and have a deeper dive. Now, Tennessee's approach to addressing maternal mortality has been challenging. Historically, the maternal deaths have been reported through vital statistics and identifying all the deaths of women pregnant and even death within that first year. So one of the first efforts to improve this identification occurred in 2012 when the state began to add a checkbox for pregnancy on the death certificate. Now, this was an opportunity to better identify women and during pregnancy, but there were still additional efforts that needed to be taken. It just did not add or even support the opportunity to improve our understanding or the state's understanding around maternal mortality issues, and or even to develop a preventative plan of action. And so as the maternal deaths continue to increase in the state, we had advocates from Meharry, our own Dr. Gwinnett Latson, the former chair of the Department of Obstetrics and Gynecology, and Dr. Connie Graves, who really pushed for legislation to begin to look at this issue closer. And from their advocacy activities, there was the enactment of the Maternal Mortality Review and Prevention Act of 2016. Now, this legislation required the formation of the Maternal Mortality Review Committee, And this is an interdisciplinary team from across the state. And their focus is to review every death and contribute to the annual recommendations of the annual review report. In 2017, this was the first year of deaths reviewed, and it also allowed for the establishment of a baseline so that Tennessee would know where do we stand with our maternal deaths. Now, as part of this committee's recommendation, there were 4 areas that they really focused on of having an overarching recommendation focus. So included community and statewide agencies, clinics and hospital systems, healthcare providers, and then of course, women and their families and friends. In the 2022 report, there was a clear refinement around prevention, specifically around the early pregnancy related deaths and treatment approach. And again, from a preventative lens, when we think about our community and state agencies, there was a mere focus on encouraging their outreach to communities and providers and educate on the resources available for mental health and addiction. And there was a hope and a push to just remove that stigma of even accessing resources to address women that were experiencing mental health crises. Around clinics and hospitals, the encouragement of supporting social work and case management services for pregnant and postpartum women, and also ensuring that training and education and implementation of protocols for healthcare providers in the management of pregnancy and postpartum complications were even addressed within the hospital systems. Among providers, ensuring that appropriate inpatient care and patients with mental health and substance use disorders were addressed, but also ensuring that appropriate treatment and management of patients, especially those with or at risk for preeclampsia, were following the American College of Obstetrics and Gynecology guidelines. For women and families, just their mere encouragement and empowering of report all your conditions to your provider. Now, 10 years after the establishment of adding just a simple box to the death certificate, and 6 years after the establishment of the Maternal Mortality Review and Prevention Act, Tennessee made another significant change and move upstream to expand coverage for pregnant women on Medicaid, which is TennCare, to a full 12 months postpartum. And they also allowed for, which allows for postpartum care, but also implementation of oral health care. These are 2 factors which have been shown and documented in the research in the literature to have significant impact on maternal health outcomes. Next slide, please. So from 2012 to 2016, the average number of maternal deaths that were able to be identified and calculated were around 74 deaths per year. The pregnancy-associated maternal mortality ratio, or the number of pregnancies-associated deaths, were per 100,000 live births. So this was 91.6 in 2016. So after the establishment of the Maternal Mortality Review Prevention Act, we didn't really see a significant decrease, but we did begin to see a different picture, and that was one of health inequities. From 2017 to 2020, there were a total of 290 deaths. 61%, or 177 of these women, experienced pregnancy-associated but not related to pregnancy deaths. They were more likely to be white, less than 30 years of age, and their pregnancy was covered by TennCare. And it's to note that in Tennessee alone, there's over 80,000 births annually, and more than 50% of those are to women on with their TennCare is their coverage. The majority of these deaths were preventable, as identified mainly through those that had substance use, and that being the greatest contributing factor. Now, only though not 39% or 113 of the deaths during the same period were found to be pregnancy-related deaths. Now, these are deaths during pregnancy and within the first year of postpartum period, where pregnancy was the aggravating factor. Black women were identified to be found to have 2.5 times more likely experience of death during this time than white women. Of the 89% of the women who experienced pregnancy-related deaths, there seemed to be preventable opportunities. Leading conditions among this group included cardiovascular and coronary disease, hemorrhage, and even mental health conditions. But for Black women, this was a totally different story. More likely to have seen Black women die from preeclampsia or eclampsia and embolism. In addressing maternal mortality, we must address prevention and health disparities at all levels, starting with the women, empowering them to share any and all their health concerns with their healthcare provider, and even when entering the hospital system. Making available resources to women during the postpartum period is essential support for helping them manage any complications, and also ensuring that there's ongoing training and education that's provided to healthcare providers at all standards and at all times, and mainly to improve health equity and addressing specifically social determinants of health that Dr. Nance even mentioned earlier in his study. These are changes that will begin to move the needle to address and change pregnancy outcomes in Tennessee. And I think we've done that quite well within Meharry's care. And Dr. Hills, I think, continues to share with us.
Dr. Hills, come off of mute. Oh, hit it again.
There we go. There we go. Good. Good afternoon, everyone. Although this is not a study regarding maternal mortality, we have come to understand that the relationship of the principal maternal morbidities leading to maternal death is informed by the data gathered by over 30 statewide maternity mortality review committees published by the CDC. As was mentioned earlier, about 50% of these deaths, of course, occur within the prenatal period up through the first week of postpartum. Another 20% from day 7 through the 6 weeks check or the 42-day comprehensive visit. And all of these, of course, as has been mentioned very adroitly by Dr. before, are pregnancy related. These are things that occur from disease, disorders, or whatever related to pregnancy. Again, obesity, hypertension, cardiovascular, whatever. The other 30% are comprehensive, or 30% occurred following the 6 weeks checkup or the comprehensive visit up through the first year. And these are primarily pregnancy associated, drug abuse, mental health, suicide, homicide, and that type of thing. However, most studies go from the first week postpartum through the first year. And if you do it that way, you have 50-50. So, but again, the pregnancy-associated problems dominate after the 6 weeks checkup time. Next slide. So what we at Meharry have done is we have compared our OB/GYN protocols and practices to the published healthcare bundles and recommendations. The first of which is the 220 healthcare bundles, which were put together by the Alliance of Innovation in Maternal Health, which was convened at the University of North Carolina in 2020 and published in the OB/GYN Green Journal in January 2021. And they talk about consensus bundles on postpartum care basics from birth to comprehensive postpartum visit. And of course, has been mentioned, we rely here in Tennessee a great deal on the Tennessee Maternal Mortality Monitoring Committee report and its recommendations to reduce maternal morbidity and mortality. What we found as we compared the recommendations to what it is we do at Meharry is that this historical and early diagnosis is very important, but this historical importance of social determinants has percolated its way up to the top. We used to worry about specific questions about health issues, but now we find that these social determinants dictate a lot of the health issues that we've been concerned about. It together with the physical examinations, again, we used to be very tolerant of obesity. Now we have grave concern based on what we've learned from these studies. And again, an early diagnosis, we're depending more and more genetic testing, of course, diabetes testing. And we find that most of these women get in trouble around the end of the second into the first part of the third trimester. So those who show us some degree of risk, we do some more comprehensive studies during the 28th week of pregnancy. Our secret sauce, however, is our early referrals to maternal fetal medicine and co-management. We are fortunate that we have an extremely experienced adjunct professor, Dr. Connie Graves, who is nationally known and who's an authority on the minority women's OB healthcare. Is Dr. Graves with us? Connie?
Here.
Oh, good. So I wanted to turn the discussion about the intrapartum and prenatal care regarding practice and policies to Connie.
Before we
maybe-
do that,
yeah.
we do have a question coming in. It's how will the recent overturning of Roe versus Wade possibly affect the social racial divide in maternal outcomes in Tennessee? And I'm sure else, because this isn't just a problem in Tennessee. And how can we address this issue?
Well, if you consider maternal outcomes as it relates to maternal deaths, let's say, we know that the percentage of individuals having babies is going to go up because the people will be forced to have children who maybe ordinarily would not have. And we think that that's going to increase about 20% of maternal, and this is nationwide, of course, maternal deaths will increase just because of this ruling. Obviously, women who are low income or more on the margins are going to have less reproductive rights as well as reproductive ability to be treated in a positive way as well. So we don't think it's going to be a really good thing. I think there are going to be people who cannot afford to go to other places, and hopefully something else will come up in the near future.
Great, thank you very much. Dr. Graves, I think it's to you.
Yes, so we are the maternal fetal medicine specialist. And we, just to give a little background, we are the largest private practice group in the city. We see patients from all walks of life. And I spent about 20 years at Vanderbilt prior and went to starting our maternal fetal medicine practice. But as Dr. Hill said, not just myself, but my partners are the most experienced practice in town. We work on what we call macros. And so in our office, if you come and you have type 1 or type 2 diabetes, we have a certified diabetic educator who actually interfaces with patients. And I just hired another certified diabetic educator. But when you are seen, your care is going to be the same because we actually follow the Society for Maternal Fetal Medicine guidelines, which I used to be a former member of the board. So our prenatal protocols include making sure that women get appropriate workup for chronic hypertension. We recently are still in a study with the University of California, Irvine, looking at cardiovascular disease in women. And I think that people who know our office know that we're very cardiovascular diagnosis forward. Preeclampsia, of course, we actually do 35 and greater. We offer genetic testing. We counsel women regarding obesity. And we also do a fair amount of counseling about disorders, including abnormal ultrasound and prenatal diagnosis, and helping women to make those decisions that are appropriate. I'm going to talk a little bit about subconscious and conscious bias in just a second, but our office offers a substance abuse counseling and treatment. 3 of my providers, in addition to what Meharry has for community resources, actually have an X license. So we prescribe buprenorphine on the spot, and we see these patients not only during their pregnancy, but up through a year afterwards. We have a specialty clinic for preeclampsia as well. So if a patient has preeclampsia, she can be referred back at 8 to 12 weeks, get her workup, see a cardiologist, and have a consultation about what she needs to do within her next pregnancy, which is so important. We know a lot of the issues that occur with complications in pregnancy are recurrent complications and not just the fact that the patient had a complication before. I am very fortunate that one of my family members, my son, is a mental health therapist, and so we provide counseling on site for patients, and we can refer patients immediately for their treatment and work in conjunction with other psychiatric resources that we have to take care of women. One of the things I think that people, there was a question that says, how do we make women who are moderate risk, high risk? I think one can say, if you happen to be African American or Black in America, you can already just check the box. And part of that has to do with bias, both some subconscious and conscious bias. The CDC and I actually co-chair the CDC ACOG committee for looking at racism, bias, and discrimination in taking care of pregnant women. The first thing I want to point out is being pregnant is discriminatory. As soon as you go to the ED and somebody says they're pregnant, everybody starts running around and acting like they don't know what to do. And so often pregnant women don't get appropriate treatment. We recently had a patient who was Hispanic, spoke Spanish only, who had promyelocytic leukemia diagnosed, who is now in remission, but even in a hospital that's a level 4 maternity center, getting everybody together to take good care of that patient was difficult. In our committee, we look at a number of things that happen to women of color regardless of insurance status, such as not being heard, such as being seen in the emergency room multiple times, such as not being referred to the appropriate level of care. If you look at the data also, you will know that women of color are often delivered in lower resource hospitals. Often not being referred to maternal fetal medicine for their care. So those are the types of things that when you talk about combating subconscious bias, letting women leave AMA and not giving them their medications as if somehow our feelings are hurt that they had to go home and take care of their 5 kids. Those are some of the things that we're bringing to the forefront in improving outcomes for women of color. Also, I want to point out that the state of Tennessee, I know that people think I don't sleep, but I do. I'm the project manager for our Perinatal Quality Collaborative, which is a TIP-QC. And Meharry has, when Dr. Ladson was very involved in our Perinatal Quality Collaborative, and Dr. Hills and I have actually recently discussed involving other faculty members. And we have developed intrapartum bundles for hemorrhage, hypertension, preeclampsia, management of acute hypertension, management of eclampsia. We have, Meharry has protocols for embolism and infections, and we also have evidence-based protocols for the management of diabetes. And you say, well, what does this matter? Well, the data out of Houston with Christina Davidson suggests that when women are treated with protocol and they're not treated under protocol, regardless of race, ethnicity, or insurance status, outcomes are much improved. Most recently, we have completed in the state our hypertension bundle, and we have segregated our data by race and ethnicity. And so Meharry was a participant and part of that. And so those are some of the things that we're doing in order to improve care in an intrapartum status. This means that if your pressure, you come in and your blood pressure is a certain level, no one's trying to figure out if it's because you're obese or because you have a family history of chronic hypertension. Those ACOG guidelines and AIM bundles that Dr. Hill talked about are very important, and we're going ahead and proceeding with treating the patients appropriately under those protocols.
Dr. Graves, we do have a question that just came through chat.
Yes.
What safety measures can be provided in other parts of the state that only have 1 to 2 hospital choices when it comes to implicit bias?
Well, great question. We across the state, our Perinatal Quality Collaborative has worked very hard in talking and discussing implicit bias. We recently at our last meeting had a presentation on implicit bias. And so we have tried to work to disseminate across the state bundles that we're currently working on in order to address implicit and explicit bias that is often seen when you review charts. For example, people will say patient had tattoos. Is that really important? Probably not, but it expresses an explicit bias of the provider.
Thank you.
I want to circle back now and just talk briefly about the postpartum bundles. The principles involved here are one of which is readiness, cognition, response, and reporting. Okay, next slide. So under the readiness, we have to make certain that people have a medical home, that there's a good planning of various sorts. The breastfeeding is very important, particularly once they leave the hospital and have to engage with community resources. And contraception, particularly tubal ligations, which we provide, is very difficult for some individuals. We do use some we call bridge contraception, or we give them Depo-Provera to tie them over until they can get to the 42-week visit where we can give them the long-acting contraceptives and what have you, and we have ongoing services. Next. Yes, recognition. Next. We have to teach people about that particular symptoms to look for that particular disease. They must allow them to have trust in their own instincts, that they come immediately for care. Don't put it off. And as was mentioned before, make sure your emergency room doesn't discharge anybody who's not seen by an OBGYN who within the first 6 weeks postpartum, because that's deadly. The referral to substance abuse prevention. I just want to mention our Rainbow program, which has been getting in effect for over 35 years, where women who have substance abuse problems during pregnancy can come, stay a few months, 3 or 4 months, be given psychological support. They can bring the infants with them, and I think that this has been a very important program. Additionally, the postpartum care team for women who are at risk for domestic violence, homicide, suicide, they have to have a postpartum care team. We have to get them, we get a relative or trusted friends, a doula, and engage with the community with social workers or case managers in an effort to prepare them to make the right decisions to protect themselves. Next. The response, obviously, when we give referrals, what have you, we have to double back, make sure they kept their referrals. And based on their social determinants, make sure they get into the right hands with the right people, with food, what have you. We have a novel affordable housing project that we're working on at Meharry, which is being headed up by our individual who's over the director of the Meharry Center for Health Policy, Dr. Rosemarie Napawisi, and we're working on that as well. Next, and finally, reporting. We have to provide the appropriate protocols to reduce prenatal, intrapartum, postpartum, maternal, and infant morbidity and mortality by using our own infant care committee reports and QA committee reports. We're able to provide innovative things like our STARK team protocol, our nurse treatment of severe PIH protocols, and we rely very heavily on the statewide data collection by the Maternal Mortality Monitoring Committee recommendations. Next. And finally, we think that the Innovaccer data analysis to be in agreement with what we find in our patient population. The morbidity risk for our privately insured employed patients and our Medicaid patients are very similar. Thank God and good luck in our practice protocols. We've not had a maternal death within the first 6 weeks in over 30 years. We're not sure about later on because we can't follow all the patients all the way out. An adoption of this model proposed by HTA Innovaccer could result in predicting at-risk obstetrical patients, resulting in opportunities for early interventions. Thank you.
Okay, go ahead, Dr. Southpaw.
I think you will see that there are some really well thought out and well researched protocols that have been addressed at Meharry in order to provide the best care and the best outcomes for our patients. It is important to realize that as we look retrospectively at employer data, we still can't give you the specifics about clinician-patient interactions, whether people are being seen by the same person over time, continuity of care, how long they can remain in care for that really important first postpartum year. And those are the sorts of things that as we look at as an analytic model, we will hope that can be included so that this is an analytic model that is sensitive to the social determinants of health, race and ethnicity, and all the biases that we know exist in care. So that it's an analytic model that is as agnostic to differences in race and ethnicity and socioeconomic status as possible. Thank you.
I just did want to point out there was another question that came through, and Dr. Graves, you were kind to answer that through chat. So in case people didn't see it, the question was in regard to family planning on the postpartum, is there a statewide initiative to ensure all marginalized birthing persons are being educated on the various methods of family planning, or are certain methods such as LARCs being pushed as priority into marginalized communities? And Dr. Graves, you mentioned that, yes, it was a priority of your TIP-QC. Anything else that you wanted to add on that one?
I think one of the things we have to also be aware of, there are even disparities here. Historically, birth control has been very much given to people who we find not desirable to birth, without a lot of information about what the birth control is, the long-term effects of things of that nature. And that was one of the takeaways we took from our quality improvement project at TIP-QC when we looked at LARC. So we not only did we improve or give LARC to patients, but we also improved the counseling that comes with that. So patients are more likely to make an appropriate choice for them and be compliant throughout their with the therapy that they choose.
Wonderful. Thanks, Dr. Graves. We do have another question that came through related to medical school education. Is Meharry or other medical schools that you're aware of encouraging or providing incentives to medical students to work in underserved communities so that we can try to impact the disparities? Is that something that's happening?
I think that our history has been that of producing physicians who primarily practice primary care medicine, and the larger percentage of which are in the underserved communities. That is what we do. That's who we are.
Wonderful.
But that is so true and a part of the Meharry mission. But in addition, a lot of the federal programs now that do loan repayment are designed to prioritize those who are serving in those under-resourced communities. So a lot of the different loan repayment programs that are at the federal level and now also at many state levels will help to pay these graduating clinicians and physicians to be able to pay back these inordinately high loans that are being taken to get through school, and that is to focus on underserved communities.
I also think that the elephant in the room that we need to mention in Tennessee is, even when we encourage people to go to outlying areas, TennCare was not expanded on the front end. So Medicaid was not expanded. And so in a lot of places, we have maternity health deserts where obstetrical services are just not available because the hospitals that provided them are now closed.
Okay, we just also, an individual in chat mentioned there's also new TenCare options available to providers, which allows for same-day insertion in the outpatient provider offices. And they're happy to share more if interested. That's Jonah. So thank you for that comment as well, too.
Chris, before we wrap up, is there anything else that's been submitted via email?
Let's see here. We have a couple more questions. So I have a question for the Meharry team. Do you have active partnerships with community resources to help ensure that babies remain healthy and get all required follow-up care? I believe you guys touched on that a little bit, but anything else you want to mention on that particular question?
I don't, any of our pediatric colleagues on the call might be able to answer that. I'm sure we do. I'm not familiar with all of them. We have one of the projects that we have is something called Nashville Strong Baby, which is a federally funded program to decrease maternal mortality in African American women and to improve the care of the infants.
Okay, thank you.
Yeah. Like Rob has a question.
Yeah, Rob. I think Rob Andrews, our CEO for HTA, would you like to? Do you have a question, or would you like to mention something? You're on mute, Rob.
Still on mute.
There we go. There we go. There we go. My question is, how can we work together to do across the country more of what we've heard about from Meharry today? The number one, so first of all, thank you to our partners and friends at Meharry and at Innovaccer and to our HTA data team. This is incredibly edifying. I wish I could tell you that I was surprised to hear the dreadful story of inequities and the effect on people. I'm not at all surprised. I'm expecting it. What is refreshing about this presentation is it didn't stop with defining the problem. It proceeded with, I thought, an authoritative, comprehensive, compelling presentation, what to do about it. And just looking at the slide that's on the screen now, and I'm not a superstitious person of faith, but reading a slide that says no maternal deaths during prenatal, intrapartum, and first 42 postpartum over 30 years. That's a compelling fact. And I don't see any reason why we shouldn't aspire to that same outcome everywhere. So I'm very, very grateful to our partners for the great work you've done here, and want to assure you the HTA is deeply committed to try to replicate these results and, where possible, improve upon these results across our country. And I'm just very, very grateful for what we've heard today.